Good evening. I am Dr. D. Silver. Now tonight we're going to discuss Parkinson's disease and focus on two new drugs that are just released. These drugs are Rasagiline or AZILECT and Selegiline or Zelapar. Both are MAO type B inhibitors, much like the old drug Selegiline. Now, a little bit about Parkinson's disease. Parkinson's disease clinically is a triad. It is tremor, bradykinesia or akinesia, which means slowing, and rigidity. The tremor is usually resting, and these three features all have asymmetry, meaning one side's affected more than the other. Postural instability does occur, but it usually occurs much later. Now, we've been really concentrating on non-motor symptoms in Parkinson's disease. Non-motor symptoms are very important, and two of them are mental changes, such as dementia, which occurs in 30 to 40% of the patients with Parkinson's generally, and depression, which occurs also in about 30%. There's also significant sleep disturbances, such as fragmented sleep, REM behavior disorder, and difficulty with getting to sleep or being excessively sleepy during the day. Now, other non-motor symptoms in Parkinson's are dysautonomias, which are constipation, sexual dysfunction, bladder dysfunction, or what we call neurogenic bladder, or sweating. Also, pain is not uncommon in Parkinson's. Untreated patients usually have back, shoulder, or neck pain, and treated patients oftentimes have pain in off dystonia. Now, the reason we talked about the non-motor symptoms because we look for drugs to benefit those, especially if the patient has what we call motor complications. Now, levodopa is related to motor complications. 30 to 40% of patients with levodopa treatment in 2 to 3 years will have motor complications, and these are divided into two types. Number one is the motor fluctuations, which is wearing off, or end-dose failure, or getting worse before the next dose. And the next type of motor complication is called dyskinesia. These are involuntary movements that usually occur a half an hour to an hour and a half after the patient takes the levodopa. Now, wearing off can be motor, as we talked about, which can be these motor fluctuations or dyskinesias, or they can be non-motor symptoms. Now, non-motor symptoms are very important, but so are motor symptoms. Now, the reason we're talking about that tonight is because both of these drugs, Rasagiline and Selegiline, help motor off times or non-motor off times. Now, the motor off times are tremor, akinesia, rigidity. The non-motor off times can be fatigue, anxiety, motor changes, difficulty thinking, or what we call bradykrinia, pain, or even excessive drooling. Now, how do these new drugs fit into our treatment format of Parkinson's? We have some very important rules we use in treating Parkinson patients. We always use this triangle: efficacy, tolerability, and safety. Efficacy is determined really by clinical trials or double-blind clinical trials. So we look at these. We also have to know the patient's drug is safe, and we also have to know it can be tolerated or it doesn't have very many side effects. Now, this slide shows us, very importantly, the treatment spectrum. We think about a monotherapy in early Parkinson patients, usually one drug. And then as the disease has its journey, we think about adding drugs on to use what we'd call adjunctive therapy or combination therapy. And we use a lot of combination drugs, usually with different mechanisms of action. You can see here for monotherapy, we have for years been using dopamine agonists as monotherapy to delay motor complications. But now we have a drug like Rasagiline or AZILECT, which can be used as monotherapy, just like amantadine or anticholinergics. So monotherapy can be used now with Rasagiline or dopamine agonists or combination therapy. We tailor, we individualize the treatment, we go low and we go slow. Now later on we're going to use levodopa. We try to delay the use of levodopa. And as the disease advances, we can see that you can then use the drug Selegiline or Zelapar and Rasagiline. Both of these reduce off time in patients who have motor complication. Now let's talk about the metabolism of levodopa. We have in the periphery L-Dopa. It's in the gut, absorbed into the plasma, and the levodopa then goes into the brain. But we want to get more levodopa into the brain, so we use a carbidopa to block the metabolism from levodopa to dopamine, and we use entacapone, a COMT inhibitor, or tolcapone to block the pathway to 3,0-methyl-dopa. More L-Dopa gets into the brain that way, about 10%. Once L-Dopa is into the brain and in the presynaptic neuron, we have a decarboxylase phenomenon that takes place, and we get a production of dopamine. Dopamine is the neurotransmitter, and dopamine can be broken down then by a significant enzyme path to other medications. But what we want to do is use dopamine or keep it around as much as possible. One of those pathways can be blocked by using an MAO type B inhibitor, like the two drugs we're going to talk about tonight, Rasagiline and Selegiline. Now this is a brief cartoon that tells us much of the same thing. And what we have is levodopa in the plasma. Levodopa goes into the plasma, it gets into the brain, and it gets into the presynaptic neuron. That's the neuron on the left. Levodopa is present. It's then metabolized into dopamine, and dopamine is the absolute neurotransmitter. It's released from the presynaptic neuron and attaches to the postsynaptic receptor site, which is dopamine. Now, for tonight's presentation, we're talking about MAO type B inhibition. And MAO type B inhibition allows more available dopamine, and that is old Selegiline or aldopril, and now Rasagiline and Selegiline. And of course, the dopamine agonists act right at the postsynaptic receptor site. Now, Rasagiline or AZILECT is our first drug we're going to talk about tonight that is the MAO type B inhibitor. Its active ingredient is really Rasagiline mesylate, and it's a novel MAO type B inhibitor. It's potent, it's irreversible, and you only take it once a day. The clinical trials have been studied not only as adjunctive therapy to reduce the number of hours of off time, but also as monotherapy in early Parkinson patients. And this has a unique propargylamine structure, which is quite unique. Now, this next slide shows us the metabolism and the characteristics of Rasagiline, or AZILECT, as the brand name is. And this drug is metabolized by the CYP1A2. That's important to point out because we have to be careful of a few drugs, like Cipro, that can make this drug at a higher serum level if they are also used in the same patients. Now, there is no amphetamine-like properties in the metabolic pathway with this drug. In this drug, there is really a aminoindan that is the main metabolite that occurs. Now, Selegiline, as compared to Rasagiline, has a little different metabolism and has different characteristics. And it's metabolized to L-amphetamine and methamphetamine and to desmethylselegiline. All big words, but those are amphetamine-like metabolites, and they can cause some side effects. But in some people, they actually get some therapeutic benefit. So this drug can cause that metabolites to be developed, and those are important things to remember. Now, Selegiline, of course, is Selegiline or Zelapar. So the metabolites of Rasagiline and Selegiline are really different, and this slide documents that. Aminoindan for Rasagiline and methylamphetamine and amphetamines for Selegiline. Now, dopamine synthesis here really is important, and what you see at the top of the slide is a presynaptic neuron. And what this complicated slide shows here really is that dopamine is not only made from L-dopa in the presynaptic neuron to dopamine by amino aromatic decarboxylation, but it's also reabsorbed into that presynaptic neuron. And it's this area where the MAO type B inhibition is probably important. And what that does is, with Rasagiline and Selegiline, it allows more available dopamine to act as a neurotransmitter. Now, this dopamine is also in other areas, but MAO type B inhibition can be in the presynaptic neuron, in the cleft, or in the glia. So monoamine oxidase pharmacology is very important. And what we have here is a phenomenon that enzymes responsible for the degradation of catecholamines is really the MAO type kind of concept here in pharmacology. And there are two forms, MAO type A and MAO type B. And the most important aspect is that we're inhibiting MAO type B. And that occurs at low doses when you use these drugs. Now, Rasagiline and Selegiline in animal models really have some consideration from neuroprotection. And that was documented in the MPTP mouse models, and it showed that if you gave these drugs and then gave MPTP, you had a greater opportunity to avoid any toxic features that these drugs really may give to the animal or even, say, to the patient. These animals would develop a Parkinson-like picture, and most importantly, that Rasagiline and Selegiline can block that toxic effect. We're going to talk about Rasagiline now. There were 3 clinical trials. This is AZILECT, it's a brand name, and there were 3 clinical trials that were done. TEMPO, the monotherapy trial, PRESTO, adjunctive therapy trial with patients who are on Levodopa, documenting a reduction in off time, which is the time when the patient isn't doing as well, and the LARGO trial, which essentially compared Rasagiline to entacapone, a COMT inhibitor. This graph shows the effect of Rasagiline in patients who are on monotherapy. And on the left-hand side, you can see that we have the mean change from the total UPDRS score, which is the score we monitor patients. In this case, you can see up is bad and down is good. And the vertical line is the mean change, and the top line throughout the graph is placebo. Down is good, and 1 and 2 milligram tablets of Rasagiline show that they can improve the patient much more than does the placebo, giving a significant improvement. And this bar graph shows us the positive effects on motor activities and on activities of daily living at 6 months when you use the patients with Rasagiline versus placebo. Again, down is good, and you can see the 1 milligram is really better than the 2 milligram, and placebo has much more of a problem with motor subscale types of evaluation. So motor improvement is present with Rasagiline, and also activities of daily living is improved with Rasagiline. And again, now down is good, and you can see the 1 milligram tablet as compared to placebo, which is on the right-hand side of each of these graphs, is not as good for the treatment of tremor or for slowness or bradykinesia. So the 1 milligram tablet does much better in treating tremor and slowness. Now, the TEMPO study was an interesting study because what they did at the beginning was they gave one group placebo and in one group 1 milligram and 2 milligram tablets, and then at 6 months they gave the placebo group in a double-blind fashion the real McCoy or Rasagiline. And you can see, again by this graph, time is the horizontal line, and the degree of change is the vertical line, and down is good. And you can see when the placebo group got the real drug, they got better, but they never caught up to the group that was on the drug from the beginning, which tells us that there may be some importance here of giving these drugs early. And this slide just tells us that over a period of time, the horizontal line is number of years, that at, for example, 2 years, you can have as many as 46% of these patients on monotherapy with Rasagiline alone. The PRESTO study was an interesting study, adjunctive therapy, and it showed that at 1 milligram, you could reduce the number of hours of off time by 1 hour. And at 0.5 milligrams, you could reduce the number of hours by 1/2 hour of off time. Off time is when the patient isn't doing as well. And in this graph, again, down is good, and you can see patients who are on 1 milligram as compared to placebo really do much better. The Largo trial was just a comparison of patients for off time who are on L-Dopa and comparing Rasagiline with entacapone. And importantly, entacapone and Rasagiline in that case was about the same. Now let's switch gears and talk about the Zydis Selegiline, or the drug Zelapar. The Zydis technology is an interesting technology. It's a freeze-dried tablet. You put the tablet on your tongue or under your tongue, and the drug is released immediately, and there's no water required. You get specific improvement in these patients really quite quickly. But the most important thing is there's a difference here in delivery. Zelapar, or Zydis Selegiline, has a buccal mucosal absorption, and it goes right into the systemic circulation, and by and large it gets higher levels, and also it bypasses the liver, where most of these MAO type B inhibitors are metabolized. The conventional Selegiline, you can see, has to go through the gut, the liver, and so on. So Zelapar pharmacokinetics are improved probably by this, and this first pass metabolism gives you higher levels of an active drug, and it gives you lower levels of metabolites. So it does give you amphetamines and methamphetamines, but those levels are lower as compared to regular Selegiline. And Tmax is shorter, and you get more of a Cmax, or the amount of available Selegiline in the plasma. So Zelapar can be used Q daily, and you only have to give it once a day. Now this slide tells us here a little bit about these aspects of Zydis Selegiline versus just Selegiline. And you can see on the left-hand side, you get more available Selegiline in the plasma when you use it by the Zydis Selegiline format. And on the right-hand side, you can see that the white bar graphs are the Zydis, and they have less amphetamine metabolites, which is probably of benefit. Now, Zelapar did a number of studies, but this is a clinical trial that shows us here very nicely that we have the vertical bar is the mean percent of off time, and we have the horizontal bar being the amount of time. And the study went 12 weeks, and here we can see very importantly is that the top group of squares is the placebo, and the bottom diamonds are Zelapar. And down is good, and over a period of time, you have significant reduction in percent of off time when you compare Zelapar with placebo. Zelapar does a better job. In fact, it's a fairly significant, robust result. It decreases daily off time when you use it in the 1.25 milligram and in the 2.5 milligram. At 1.25, you get an improvement that's significant, but when you get it up to 2.5 milligrams per day at a later period of time in the titration, you get as much as a reduction of 1.6 hours in the off time. And that's fairly robust. Taking all medications, dopamine agonists and others, that's a very significant, robust reduction in off time. Now this is a slide that shows when you use Zydis Selegiline or Zelapar, you get an increase in dyskinesia-free daily on time. And what does that mean? That means the patient has more on time, and they're dyskinesia-free. So dyskinesias can be troublesome. And you can see here on this slide, on time is a vertical bar, and we have two groups of bar graphs at 4 to 6 weeks and 10 to 12 weeks, and we can see that the mean change from on time is significant when you use Zelapar as compared to placebo. So Zelapar is beneficial, and dyskinesia-free on time is significantly improved. Now, there's always adverse side effects. Remember the triangle: efficacy, tolerability, and safety. We have discussed for these drugs efficacy, proved by clinical trials. They do have some side effects. Rasagiline has some side effects. By and large, it's about the same as placebo, generally. Zelapar has some side effects. Some of the ones we see is nausea, dizziness, insomnia, and increased dyskinesia. Now, it's important here to consider that there are some warnings that we always have to think about with MAO type B inhibition. MAO type B inhibition takes place in the presynaptic neuron in other areas. It allows more available dopamine. So when that happens, we have to think about other interactions that can take place. Let's talk about the medication. Now, we know, and we've had a lot of experience with an MAO type B inhibitor like Selegiline or Depranyl or Eldepril for years. I've been using that drug on patients with Parkinson's for many years. We've always been a little cautious, but as time has gone on, we've felt very comfortable using this drug with these various medications. Now, the medication that I want to emphasize here that we have to be concerned about are pain medications, some cold medications, antidepressants, and other MAO type B inhibitors, but also MAO type A inhibitors like some of the antidepressants. And for Rasagiline, we have to think about the CYP1A2 enzyme inhibitors, especially like Cipro. Now, we know that we have two new drugs. We have Rasagiline or AZILECT, and we have Zelapar or Selegiline. We always have to remember that it takes 100,000 patient exposures to pick up just the most idiosyncratic drug reaction. That's a very important aspect. Tolcapone or Tasmar with liver difficulty was a classical example of that. So for pain medicines, we want to stay away from Demerol, especially if a patient's going to have surgery. They got to have the medicine stopped for about a number of weeks before, usually 2 weeks. We have to think about cold medicines. We have to be careful about using drugs that can make symptoms worse, such as dextromethorphan. We have to not use medications that have that DM designation. Antidepressants are very important, and we like to be concerned about giving these drugs to patients that are on tricyclics, like amitriptyline and SSRIs. Now, with Rasagiline, they had these drugs present in some of their clinical trials, but still we have to be cautious. And of course, Selegiline has been used with these drugs for numbers of years, and there by and large been little or no problems. The ones we're concerned about is the serotonin syndrome. Also, MAO type B inhibitors like Selegiline can't be used with these two drugs. And we've talked about the CYP1A2 enzyme inhibitors, Cipro. I'm going to briefly mention about tyramine. Probably the FDA has allowed the situation with tyramine and Selegiline not to be a major concern. But we still have to consider that. But there is a warning about tyramine and Rasagiline or AZILECT, and that is mainly with food products, and that it'd be a long discussion to talk about tonight, but there is information that you can get on various websites, and one I'm going to give you is going to be www.pdasd.org. There will be a list of considerations of foods with tyramine on that website that we'll be able to have you consider. They're mainly foods that are aged in some way, cheeses, meats, and red wines and other types of products. Tonight, we've tried to talk about two new drugs that have been very important, I think, in the new armamentarium for the treatment of Parkinson's disease. We've reviewed Parkinson's disease and Parkinson's disease treatment, told you how these new drugs fit in. We've reviewed MAO type B inhibition, and we've talked about it, how it occurs in the presynaptic neuron, and the two drugs that play a role that we've talked about tonight. These two new MAO type B inhibitors, as I mentioned, are Rasagiline or AZILECT, or Selegiline or Zelapar. We need to have a little more comfortability in using these drugs and see how they do. We have to be careful of some of the contraindicated drugs and also some of the warnings and concerns. Thank you for joining us tonight. I'm Dr. D. Silver. Good night, thank you, and good health. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin.